Hello, my name is Jongmo Park, the President of Prof Asia and the Editor-in-Chief of Prof, and the co-chair is Professor Ki-chul Sung, the President of Korean Vascular Research Working Group. The journal Prof, an official journal of Prof Asia, is the international journal on comprehensive care and prevention of vascular disease. This is the first live webinar organized in collaboration with the Prof Asia and the Korean Vascular Research Working Group. The topic of the webinar today is the 2022 highlights from Perth, Cuffless blood pressure measurement, challenges, and the future. We invited two distinguished professors on this field, Professor Avolio and Professor Seo. After two expert presentations, the commentaries from the two panelists and questions from the audience will be followed. Of two panelists, Professor Chen Wen-Chen, he is also immediate past president of Prof Asia and currently Dean of School of Medicine, National Yangmin University, Taipei, Taiwan, and Professor Hae-young Lee at Seoul National University in Seoul, Korea. He is a distinguished clinician and cardiologist. We very welcome questions from audience. On the right side, if there is a question box, you can upload your questions during or after presentation, and they will be discussed. I will introduce the first speaker, and Professor Sung will introduce the second one, and go on with the discussion. And so, I will introduce Professor Avolio. He is past president of Prof Asia and from Macquarie University School of Medicine, Sydney. He will be talking about challenges presented by Cuffless measurement of blood pressure if adopted for diagnosis and treatment of hypertension. Now, Professor Alberto Avolio, could you start?
Thanks. Is my screen coming through?
Yes.
Okay. Thanks very much, Jongbae, as President of Prof Asia, and thanks, Kaga, for organizing this series of webinars. And I think it's timely. I think it's part of what we've been used to with the COVID. The times that we can actually make some good use of the digital technology. So I was asked to be the first speaker of this webinar series. And the topic is challenges presented by cuffless measurement of blood pressure if adopted for diagnosis and treatment of hypertension. So it's this caveat whether it's useful for diagnosis. But I think what I'd like to do is to discuss some of the underlying concepts involved in the cuffless measurement of blood pressure. I'd like to present, in fact, this is a review and work done by our group, by all of these people here, and I'll be presenting some data by two students, higher degree students, James Cox and Kira Luca. So the topic of this webinar is challenges and future, and I think it's important to look at what people are saying about the future of hypertension. And essentially, the future is that it needs transformation. There's been very slow progress in recent times on the global control of hypertension. And there's very, very new research that has actually made major advances. And what they're saying, and this is in fact a review article by Victor Zhao and his colleague published in Hypertension a couple of years ago. What they're saying is that in fact the field should enter the digital transformation area, and so this will change the way care is delivered because there will be a shift, a trend to shift away from the conventional hospitals and clinic to personal medicine delivery in daily settings in the home and so on. And so one of the areas they propose that needs to be looked at as a major advance is cuffless measurement of blood pressure. Because as we know, if you have continuous measurement of blood pressure, you might open up a whole different way of looking at this problem. So if one does a Google search on cuffless blood pressure and watch, one obtains pages and pages of these types of devices. So there are many devices out there already that claim to measure blood pressure. Most of them are watch-type devices with connectivity to mobile phones, and they all have some type of sensors, mainly photoplethysmography sensors, light sensors, infrared, and electrodes that measure ECG. So usually the measurement is ECG and some pulse and a PPG. So it's this time, the time between the R wave and the pulse, which is the pulse arrival time, or sometimes between two pulses, which is the pulse transit time. That is then correlated with measurements of blood pressure, and one obtains scattergrams like this with some form of correlation. And in this case, correlation of R squared of 0.6 for systolic and 0.3 R squared for diastolic. And then there is a measurement of blood pressure. So the question is this technology ready for diagnosis and treatment of hypertension? And I think before we answer this question, it's a very important question. It's not a yes or no. Is in fact lots of gray areas. How much are we prepared to face the challenges to make this happen? So in terms of diagnosis, we know that there are thresholds, and these of course vary. These are the US ones, the latest ones. And then there is criteria based on night, day, ambulatory blood pressure monitoring, dipping, non-dipping patterns. And in treatment, there is regular monitoring. And the important part is that in the conventional treatment, we trust that the measurements we get with the cuff sphygmomanometer actually tell us something about what the drug is doing. Is it lowering blood pressure? And is it tracking changes? And this is done with trying to minimize errors as much as possible, minimization of errors in the measurement, so that we can trust the measurement. With the cuffless application, if we look at the same things, do we use the same thresholds? Maybe. Same values? Or will they be modified based on daily activity? Will it be the same type of other criteria with dipping? Because this is a problem. Will we be able to trust the dipping and non-dipping with cuffless devices? And in the treatment, yes, I think we can say that they will be able to provide regular monitoring. But the big question is, do we trust the measurement that reflect the activity of the treatment? And is the tracking of blood pressure changes meaningful and true? And how much do we minimize the errors in the measurement? So in understanding these challenges, I think what we need to understand some of the underlying mechanisms involved in translating a physiological arterial pressure to a cuffless blood pressure measurement. And we also have to understand the factors involved in a change of blood pressure and how it affects the actual measurement. So I'd like to discuss a particular sort of approach to this, where the effects of changes in blood pressure, those that might be driven by cardiac, vascular, and urogenic mechanisms. And so how these affect the association of blood pressure and pulse transit time, which is the main measurement that is used for cuffless devices. And the association, of course, is the basis for the measurement. But of course, it's the pressure in large arteries, and we tend to forget this, that this association of blood pressure and pulse transit time, in fact, is only relevant, truly relevant for large arteries. So let's recap a little bit what we know about blood pressure measurement. Now in the cuff, using the cuff sphygmomanometer, the actual measurement that we do is a pressure measurement in the cuff. So it's a calibrated cuff measurement. Calibrated if we use a transducer, and if we use a column of mercury, one doesn't need calibration. We trust gravity. This is very accurate. It's not true that the measurement of brachial blood pressure is not accurate. It is probably the most accurate measurement we have in medicine. That measurement, this one, the measurement of cuff pressure. What is relevant is that the association of that cuff pressure with arterial pressure occurs through secondary phenomena. And these are usually either blood flow or wall vibrations related to Korotkoff sounds. In the cuffless measurement, there is no pressure measurement, right? So we have a pressure value with no pressure measurement. That's important to understand. There's no force measurement in these cuffless measurements, other than a potential, maybe a transducer that detects the waveform. It is an uncalibrated signal, and it's used essentially for, as we said, for time delays or for feature extraction. And the association is the wall properties, is the properties of the arteries, which is the arterial stiffness. And this is directly related to the pressure. So these wall properties are highly relevant in relation to what the transmural pressure is. So for cuffless measurement of blood pressure, we know that any modification of the mechanical properties of the arterial wall will affect the calibrated measurement of arterial pressure. So in arteries, there's the material properties, elastin, collagen, extracellular matrix, and so on. And there are also active elements, and the active elements are the endothelium and the smooth muscle. And these, when activated, could potentially alter the stiffness, which is different to altering the stiffness with pressure dependency. So I'd like to just clarify some of these concepts here. Before I do that, I just want to remind us whether we ask ourselves, what is blood pressure? When we talk about blood pressure, we're talking about pressure of blood in a closed compartment, which is the arterial compartment. And so we're talking about arterial pressure here. And it's arterial pressure because the arterial wall is under tension. If there is no tension in the arterial wall, blood can still exist in the closed compartment and there will be no pressure. So the origin of arterial pressure is a distended arterial wall. There has to be tension in the wall. The other concept is a pressure dependence of arterial stiffness. So it's relevant to cuffless measurement of blood pressure because it has these associations. Stiffness related to pulse wave velocity, transit time, which is the inverse. And so the surrogate measurement, as we said, is usually a transit time. And it is relevant because of the pressure dependency of arterial stiffness. So where does this come from? It comes from the fact that there are very biophysical relationships, and the main one is called the Morse-Korteweg equation, which says that the pulse wave velocity is related to the elastic modulus, the wall thickness, the radius, and the blood density. Now, this is a well-known relationship, but we forget that it's valid only for thin-walled tubes where the wall thickness is much less than the radius. And also what we tend to forget, that it is relevant for very uniform segments, which obviously sometimes apply to arteries and sometimes do not. So, as I said before, there are passive and active mechanisms here. So that the passive ones are essentially changes in wall stiffness with blood pressure, and the active relate to the molecular and cellular effects that could alter the vascular structure. So the passive modulation of arterial stiffness is mediated essentially only by properties of the arterial wall, the mechanical properties. So for any mechanical properties, we have stress, strain, or pressure, area, or diameter. And these relationships in arteries are not linear, they're curvilinear. And at any point, at any pressure point, the slope of that line is the stiffness. And these curves, this is a curve for one artery, that's a curve for another artery, old and young, or different arteries in the same person. They have different curves. So for the same value of pressure, the stiffness of these different arteries will be different. And the stiffness, the slope of this curve, you can see that it increases with pressure. So that's the relationship that is relevant in cuffless measurement. The stiffness of the wall, which is then related to pulse transit time, depends on the pressure. But these curves here, the way the curves are made, as it were, depending on the arteries, will determine the sensitivity of that measurement. And so, and the relationship, of course, is the Laplace law, which balances out the tension in the wall and the pressure. So, what is the active modulation of arterial stiffness? It's mediated by essentially vascular smooth muscle. So in this respect, I'd like to just describe some quite old studies done some 50 odd years ago. Bill Dobrin, he was a cardiothoracic surgeon, and they looked at canine carotid arteries in organ baths, and they stimulated the smooth muscle by using a norepinephrine or potassium cyanide. So norepinephrine contracts the smooth muscle, potassium cyanide relaxes it. Measured stress-strain relationships, and then looked at what happens when we alter these relationships. So this is the stress-strain, and this is the curve of the artery, and as I said, they're curvilinear. But what is relevant is that at a particular level of strain, therefore blood pressure, the stiffness here is different to this one. So for the contracted muscle, the slope is higher than the relaxed muscle. So the contracted muscle stiffens the artery. And the difference, of course, between those two is the actual tension in the muscle. So smooth muscle contraction increases wall stiffness. So if we plot, excuse me, if we plot the slope of these, which is the stiffness, which is the elastic modulus, as a function of strain or as a function of blood pressure along here, we can see that the stiffness of the contracted artery is always higher than the relaxed artery until we get to a particular point. And after that point, as the artery is more distended, usually with higher pressures, in fact, the contracted artery becomes less stiff. Right? Smooth muscle contraction reduces the stiffness. Now, why is this relevant? Smooth muscle contraction could be related to increases in blood pressure that we are measuring as increased transit time, we think, but in fact, in this case, it would be a decrease in transit time if it were measuring stiffness. So, and the same thing if we were to plot the contraction with transmural pressure, and you can see that this is really important sort of manifestation, how the smooth muscle is maximally active at the normal operating pressure, where most of the, I suppose, regulation, arterial regulation is to take place at these normal pressures. So what does this mean? This means the same thing, that the elastic modulus of a relaxed vessel compared to a contracted vessel are different. So on this side, at low pressures, where the smooth muscle tension is increasing with blood pressure, the arteries become stiff, right? They're stiffer here. The contracted muscle becomes stiff. Whereas at higher pressures, the contracted vessels become less stiff. Now, these are important illustrative examples of what we're talking about when we're saying that there are active components in the vasculature that could act as confounders to what one is measuring transit time as a surrogate measure of blood pressure based on changes of arterial stiffness. So the other aspect I'd like to mention is the various components that determine blood pressure or changes in blood pressure. So the mean pressure is a function of cardiac output and peripheral resistance, stroke volume times heart rate. And if we have a delta change in pressure, say a relative change, the relative change in pressure is the sum of the relative changes of these components. So it's the sum of the relative change of, say, if there's a 3% change in blood pressure, 1% plus 1% plus 1%. That's if they're the same. So what we're saying is that all of these components become relevant in understanding what is measured when there is a change in pressure. Pulse pressure is related to stroke volume and arterial compliance. And so the change in pulse pressure is a change in stroke volume with a negative change in pulse transit time. So essentially, the stroke volume and heart rate components are cardiac dependent. They're due to the heart, the components that affect blood pressure. Changes in compliance are due to stiffness, and changes in peripheral resistance are essentially microcirculation affected by these other factors like neurogenic or potentially endothelial function. So the determinants of components that the determinant components of blood pressure that Cuffless devices use when there is a change in blood pressure is important to understand how they relate. So the components that contribute to blood pressure could also contribute to an additional error in the measurement of pulse transit time or pulse arrival time due to these physiological mechanisms. Which means that if this is the case, this association that we take for granted of blood pressure and pulse transit time or pulse arrival time is not entirely preserved. So if we just go through these things quickly, the relative change in stroke volume, well, what could that do? It could increase, if there's a change, if the blood pressure change is due to a change in stroke volume, it could increase the distension of the vasculature, probably change the operating point of those curves, possibly alter the amplitude of the peripheral PPG, which could then affect the change of the accuracy of these features that is used to measure transit time. Heart rate, what does that do? It could alter the upslope of the peripheral PPG signal that again could also affect the fiducial point or to detect the pulse transit time. It's been shown that there is a small effect of heart rate dependency of pulse wave velocity, independent of blood pressure. The arterial compliance is totally affected by blood pressure itself. And some error could then be produced by the neurogenic effect of smooth muscle in the larger conjugate arteries that are a part of the total compliance system. The important one, I think, is the peripheral resistance, which this one could contribute to a significant error due to the neurogenic effect of arterioles, and could also affect the propagation phenomena in small arteries where there is effect of viscosity. And so there is effect of damping of the peripheral signals. So the effects of interventions employed to produce a change in blood pressure that are associated with pulse transit time. So I'd like to just describe briefly 3 different experiments to illustrate these potential confounders. One is some experiments on multi-site PPG measurement. Another one is comparison of tonometry and PPG measurement of pulse arrival time. And the other one is the consistency or the stability of calibration. So this is some study that we did with some colleagues in Italy, Dr. Derienzo. They instrumented the subjects with PPGs in the forehead, the finger, and the ear, and a seismogram at the chest, where they were able to measure the opening of the aortic valve. So the ECG, the seismogram, and the 3 PPGs. And from those, you could have very accurate measurements of pulse transit time from the opening of the aortic valve to the foot of the PPG pulse, and the pulse arrival time from the ECG. So 20 people, cold pressor, hand grip, and cycling were the 3 tests that were administered to these people. Blood pressure was measured continuously with the finger. Transit times were measured. Isovolumic contraction time is simply the difference between the pulse arrival time and the pulse transit time. So period of rest, 5 minutes, tests with the rest periods in between. And so this is the result. And I know it looks complicated, but essentially there's a very important result here. All of the tests here, rest, and then all of them showed an increase in systolic pressure and also in diastolic pressure. All of them. Only not all tests showed changes in pulse transit time. So even though there were changes in blood pressure, pulse transit time did not register those concomitant changes, except in the cycling, right? Now, there was some, for example, in the finger and so on, but generally, the only test from which the pressure was similar to the other ones, there was a change in the transit time, was the cycling. So, and this shows the same thing, but what's important here is it shows that the number of milliseconds that were affected by these tests, very few, very low milliseconds, 10 milliseconds, whereas here 50 or 60 with the cycle for similar changes in blood pressure. And of course, when you break it down, a lot of the changes for these tests happen in the pre-ejection period, which is actually not measured with the pulse transit time. It's included in the pulse in the measurement. This one shows the correlation. So the maximum correlation between blood pressure and transit time is actually quite low. It's about 0.2 or 0.3 for these tests, but with exercise it can go up to 0.8. So and this shows that the correlation of pulse arrival time and pulse transit time. And again, there is some correlation, but it's maximally. So when there is a particular type of test to change blood pressure, there is a higher correlation with all of these measurements. So when one looks at the sensitivity, so this is rest, cold pressor, hand grip, and cycle, right? Again, this is changes in mean pressure. For those that had some significant change, look at the difference in sensitivity between one and the other. Can go 5 or 6 times. And most of it is related to the pre-ejection period. So the effect of those changes, which is not seen, can be seen with some sensitivity in the pre-ejection period. And this is an example to show that here is a situation where if you were to say, does pulse transit time track changes in blood pressure? The answer is no. Change in blood pressure, reflex heart rate, very little detection of change in pulse transit time of all of these sites. How come? Is it a bad measurement? It might be. Or might it be these types of confounders we're talking about? These other measurements were looking at the use of tonometry to measure the pulse compared to the PPG. And I put this to show what actually goes on in measurement of the PPG, that is different wavelengths that are actually damped at in different regions of the vasculature. And so the smooth muscle activation could potentially alter the waveform features. So the aim was to look at transit times measured with a PPG in the finger and the radial tonometry in a group of 15 people, only with one single test this time, with cold pressor test. So this is the 15 people, and this is the ranking of blood pressure changes. So some people had high blood pressure change with cold pressor test, others had low. This is in the order of ranking. And this is the pulse transit time. They do not rank in the same order. Some of them had much higher changes in pulse transit time compared to the blood pressure than some others. So generally, there is a trend that pulse transit time ranks with blood pressure. And both, tonometry, there is some association with the tonometry and the PPG, but they don't coincide in all cases. And so if we look at these are the changes when we look at, say, a high, medium, and low tertile. And so the pulse arrival times that it changes are different for each category. And that's the relation. So this is looking at the sensitivity, right? The sensitivity, how many milliseconds change per millimeter of mercury. And so for the tonometry, there's a certain amount of change, but for the PPG, there's a greater change. In the middle range, the tonometry and the PPG are similar. So this means that the sensitivity of this measurement depends on the level of blood pressure. Another one is looking at, this is the variation in the sensitivity of that particular measurement. Another one is looking at the consistency of calibration using a 2-point. Now, a lot of these devices ask you to measure blood pressure and measure the transit time, and that's the calibration. So usually, if there is a single point calibration, for example, one blood pressure measurement corresponds to one transit time measurement. If there is a change of blood pressure, what will the device do? There has to be some slope that is put in, some calibration. And so you can see, depending on what slope the device has, will determine what is the next measurement of blood pressure if it changes. Now, of course, that can be fixed if one has two measurements, so 2-point calibration. And you can see that the same change in transit time with these different calibration points could actually achieve different values of blood pressure. That's the first point. The second point is, how do we obtain reliable or reproducible changes of blood pressure that we can calibrate the instrument? So if one measures pressure in the arm at different locations, 45 degrees, you can obtain, in fact, quite a good reproducible estimate of blood pressure with arm position. And so if one were to do that, you could obtain a calibration curve. And so this calibration curve with blood pressure and pulse arrival time at different points, right, that this could be used then as a metric. So in this case, there is a slope and intercept. And so that slope and that intercept could be used as a measure, as a metric, to see how stable the calibration is. So in this study of seven people, blood pressure was measured with the tonometry, with a brachial cuff, and pulse arrival time was measured with a tonometer. And so there were readings taken over 2 months, day 1 to day 60, and this slope and intercept used as metrics. So again, this is potentially complicated slide, but it's not. This is calibration, the slope of compared to day 1, right? If they were the same, all the points would lie on this curve here. So these slopes change with different days because compared to the day 1, they're different. That's what this means. And so this is the variation of these slopes and intercept, that day 1, day 2, day 30, and day 60 compared to day 1, very different. If one were to do a statistical test on these, you would say no difference. So the statistics say those calibrations are all okay, but in fact they're not. If we use those calibrations in individuals, we will get hugely different values of derived cuff pressure for those calibrations on those different days. So to conclude, what I'd like to say is that the relationship between blood pressure and pulse transit time or pulse arrival time is actually quite complex and depends on a range of phenomena related to arterial structure, function, and hemodynamics. The modulation of active tension in vascular smooth muscle could have a substantial effect on the association of blood pressure and pulse transit time. And the relevance of different sensitivities of blood pressure and transit time with these associated confounding factors might need to be considered when in fact formulating device validation procedures. But we know that universal acceptance of a reliable cuffless BP device that delivers meaningful readings could actually lead to really useful information in terms of awareness of hypertension. And whether we like it or not, there is a current surge in research, commercial, and clinical activity that's going to lead to increased consumer adherence to wearable devices that include blood pressure as the suite of measurements of vital signs. However, with these underlying challenges that we've just talked about, as presented by cuffless devices, there is yet no strong evidence that they could reliably replace the brachial cuff sphygmomanometer for diagnosis and treatment of hypertension. Thanks very much.
After another speaker is Dr. Jongmo Seo, and the Kitcher Sang will introduce him.
Okay, thank you, Dr. Bach and Dr. Avolio. I'm Kitcher Sang, a current president of Korean Vascular Research Working Group, and I'd like to introduce next speaker, and his name is Dr. Jongmo Seo from Seoul National University and Seoul National University Hospital, and he will be talking about photoplethysmography and tactile mechanical transducer for non-invasive continuous blood pressure monitoring. And we have Dr. Hae-young Lee as a designated discussant for this talk. And Dr. Seo, would you start, please?
Honor and pleasure to give a talk in this web seminar, and I'd like to quickly review the current status of photoplethysmography technologies and tactile mechanical transducers for non-invasive continuous blood pressure monitoring. And many parts of these slides were shared by Dr. Hae-young Lee, and I really appreciate on this. Well, three major different technologies have been investigated for the continuous blood pressure monitoring. The first one is ultrasound-based NIBP, and the second one is photoplethysmographic-based NIBP, and the third one is tactile sensor-based NIBP. And due to the size and the weight of the ultrasound-based NIBP, I'd like to focus on the PPG-based and tactile sensor-based NIBP in this talk. As everybody knows, photoplethysmography measures the plethora of the skin, which is a result of the blood vessel engorgement under the skin and inside the skin. And by illuminating the skin with red light, we can measure the reflected or the transmitted light through our skin. And as Dr. Avolio already showed, many different type of wrist-worn type PPG-based devices. I would like to show these two, the Actia and the Samsung Galaxy Watch. And the Society of Korea Hypertension is doing under clinical trial with a Galaxy Watch for the possible candidate of the daily measurement of the continuous NIBP in these days. And the wrist-worn PPG-based device measure the plethora of the skin and under the skin artery, mainly focused on the anterior interosseous artery, And this artery reflects the blood pressure moderate well. And the other type of the plethora measuring devices like earable devices, which can measure the plethora of the skin on the our earlobe or our eardrum. And in these devices are under investigation, and these devices are not commercially available until now and in the market. Only a pilot study devices are available. And the other type of the photoplethysmography is a video-based PPG, which is proposed by neurologists, and they show the feasibility of the phase-based PPG by providing heart rate and the breathing rates, and some sort of the heart rate variability and a moderate amount of blood pressure monitoring ability. And the video-based PPG is video-based PPG utilize the color image, which is reinterpreted from RGB color space to LAB color space. That is to say, the LAB color space utilize the component of red-green balanced color channel by dividing the color information as the first one is luminance, and the second one is R and G balance, and the third is yellow and green balance. And as you can see on the luminance and the R and G color balance shows the good PPG values on the video-based PPG. However, there are some limitations in using video-based PPG. The most challenging part of the PPG-based blood pressure assumption postulation is that if we measure or estimate the blood pressure in the peripheral information of the PPG, then as Dr. Avolio told us, the information is not exact to the real blood pressure. So we should adopt several different parameters to estimate the original PPG, like using the pulse transit time and vascular time interval between the first heart sound and the systole peaks and so on. So many PPG-based devices utilize the second information, like the slope or electrocardiography or the cardiac sounds and so on. And according to the location of the PPG source, all these parameters should be properly modified. And Dr. Avolio showed us such kind of aspects in his talk already. And also, there are several challenges in measuring the optical cardiac monitoring by using PPG signal. The first one is that the PPG is so much affected by the skin color, because we utilize the color information of the skin reflected or transmitted by the red light source. So the skin pigmentation is very important factor in analyzing PPG signal. And the second one is that the PPG signal is so much affected by the motion artifact. The simple waving of our hands with a wrist-mounted PPG device will make so much noise, as shown in the left lower figure. And also, if someone walks with their wrist-worn device, then each step will mimic the heartbeat, and this kind of step beat will may override the real heartbeat. So this is called a crossover problem, and this can make the second parameter to correct the PPG signal not appropriate for reinterpreting the PPG signal to the real BP. And the third one is that if the skin is exposed to the cold or cold situation, then the skin, amount of the skin flow is skin blood flow, the capillary skin blood flow will be so much decreased. So the variability of the PP signal will increase. And so all these kind of challenging problems make the continuous real world PPG-based NIBP difficult. So the Society of Korean Society of Hypertension is doing clinical trial for measuring the NIBP in the real world, not in continuous manner, but as an intermittent manner. And the full data of this clinical trial is not yet published. So I would like to show us some glimpse of the data. And as you can see, more than 700 persons are participated in this study, and more than 10,000 data points are acquired. And as you can see, relatively moderate reproducibility within 2 millimeter mercury of the systolic BP variants are observed in the weekly based, and also the daily based monitoring is quite good. The variability of the systolic BP is almost within 2 millimeters mercury in 24 hours monitoring, and we hope this data to be published soon. And so the other method for the non-invasive continuous BP monitoring is applanation based, or that is in other words the mechanical device based blood pressure monitoring, which do not use the cuff or over the brachium. The most well-known type of this applanation tonometer is the Miller tonometer, and the Miller tonometer is very similar to the Goldman tonometer, which is used for measuring the intraocular pressure in the field of the ophthalmology. And the principle of applanation is like this: if we apply some force device over the spherical or cylindrical structure, then the flattened area will reflect the internal pressure of the cylindrical or the spherical structure. So that is to say, if the pressure inside of sphere or the cylinder is very high, then the flattening area, which is shown as A, the red A, red colored A, is small. And if the pressure inside the sphere or the cylinder is low, then the flattened area A will be large on the same force provided by the plunger. That is to say, if we apply the pressure with a appropriate flat plunger over our arterial, the radial artery area, then the pulse of radial artery, that is to say, the internal pressure of the radial artery, can be measured by the amount of the flattened area of the plunger in this rod type tonometer. The similar principle based device are provided by the Omnon tonometer in these days. They are under investigation. So there are small plunger-like structures inside of this device, and according to the pressure inside of artery, the flattened area of the artery provided by the pressure of this small group of plungers will be proportional to the pressure of the pressure inside of arteries. So that is to say, if we count the number of the small array of the plungers recruited to flatten the artery during the measurement session, the number of the recruited plunger will be proportional to the internal pressure of the artery. So we can estimate the internal pressure of the radial artery. However, this device requires the calibration. So the reproducible calibration is the most important part of this kind of applanation tonometer type device. So to overcome the size and the difficulty in use, like for example, the Miller tonometer always requires a perpendicular, very appropriately applied position over the radial artery, and so if the applanator is not in perpendicular position, then the measured pressure is not a real artery pressure, and also if the Omnon tonometer is not appropriately applied as a perpendicular manner, then also it will make the similar result with a similar error as a Miller tonometer. So to overcome this kind of difficulty, some people would like to develop the silver nanowire-based tactile sensor, because the silver nanowire-based tactile sensor can show the difference in their resistance, current resistance according to the stretching or bending, and even on the pressure over the sensor. So the paper says that this kind of patch can be applied over our carotid artery or our radial artery, and this sensor can provide the pressure sensor like waveform according to our heartbeat, and they insist that this kind of sensor can be a candidate for the continuous blood pressure monitoring. However, in our lab, we also did the similar work with a silver nanowire-based tactile sensor, and we found that the silver nanowire-based tactile sensor shows a different values on their stretching phase and their relaxation phase, and also in case of bending, during bending and relaxation, they show a different curve according to the amount of stretching or bending, or even on compression. This is partly due to the thickness of the silver nanowire embedded polymer, because the polymer is usually the polydimethylsiloxane, the rubber-like polymer, and the rubber itself provide a damping effect, And as a result, during stretching and relaxation, or bending and relaxation, there is a discrepancy. So this kind of sensor should be more thoroughly investigated to be used as a pressure sensor. Instead of using the silver nanowire-based sensor, we also investigated the tactile force sensor, which is developed by Professor Seoul at the PPKE in Hungary. And this kind of tactile force sensor utilized the dome-shaped rubber, and according to the flattening of the rubber dome, we can measure the force, just a similar way as a applanation tonometer. However, compared to the current applanation tonometer, this dome-shaped force sensor shows always perpendicular measurement in any direction of the dome surface, because any part of the dome can make perpendicular contact of any pressure generating surface. So we found that this kind of dome-shaped force sensor is more useful than the planar type applanation tonometer. So we compared the dome-shaped tactile force sensor with a Miller tonometer, and we found that it shows the similar result with a Miller tonometer. And also we found that this 3-axis tactile force sensor can repetitively and continuously measure the NIBP very reproducible manner in systolic and diastolic pressure. And also we are under investigation of using this 3-axis tactile force sensor for measuring the orthostatic hypotension, the blood pressure change. And in our experiments, it shows a very good reproducibility on the orthostatic BP change. And also we are evaluating this kind of 3-axis tactile force sensor for measuring the pulse wave velocity by applying this on the carotid artery and the radial artery. And in conclusion, I think that PPG-based wrist device shows a promising result in monitoring real-world NIBP. However, it may not appropriate for the continuous measurement NIBP. Instead of measuring the continuous NIBP, PPG-based wrist device may be better in measuring intermittent NIBP. And the tactile sensor-based device may be used as an in-house monitoring device for continuous NIBP for evaluating the orthostatic changes or the autonomic nervous system problems, such as Parkinson's disease and other pathologic blood pressure conditions and so on. And also, there are another very interesting device in these days. As you know, everybody uses smartphone, and the smartphone uses the touch screen for detecting the touched area and for monitoring the infant or the premature baby in neonatal intensive care units. If the infant is laid on the touch screen, then by monitoring the area of the contact with the chest over the touch screen area, we may analyze the heart rate and the respiration rates, and even we may estimate the blood pressure of the premature baby. And this graph shows the such kind of predictive function of the touchscreen as a valuable candidate for the BP and heart rate and respiration rate monitoring device. Thank you for your listening.
Thank you. Thank you, Dr. Seo. As we noticed, we have two designated discussants for this webinar, and Dr. Chen Hao Chen for first talk and Dr. Hae-young Lee for second talk. I think Dr. Park may lead the other discussion. Dr. Park, would you lead the discussion?
Could you start?
Yes, thank you very much. And I enjoyed the two lectures very much. Now I would like to comment on Professor Avolio's speech with 3 questions and answers. Now, the first question is, how accurate are the cuffless blood pressure devices expected to be when there is no actual measurement of force by the device sensors? My answer is, cuffless blood pressure devices are not accurate. As pointed out by Professor Avolio, the main types of cuffless blood pressure measurement devices are watch-type devices with sensors that typically recorded a PPG and ECG signals. The device do not actually measure blood pressure, but estimate a blood pressure value using a time delay and from the PPG ECG signals, based on a rough and highly variable inverse relationship between the time delay and blood pressure. And the inverse relationship between the time delay and blood pressure itself is derived from the positive but moderate relationship between arterial stiffness and blood pressure measured within an arterial segment. So in theory, use of the pressure dependency of arterial stiffness phenomenon alone could never provide an accurate blood pressure estimation, even in the absence of noises, because of the regional and temporal variability of arterial stiffness and blood pressure along the arterial tree. And the arterial stiffness and blood pressure relationship is not fixed and may change over time. Furthermore, the PPG sensor is sensitive to slight movement, so it is imperative to hold still while taking blood pressure, and therefore it is very difficult to provide reliable blood pressure readings during ambulatory conditions. And I would like to comment on the second important question. Can the cuffless blood pressure devices reliably replace the cuff blood pressure devices for diagnosis and treatment of hypertension? My answer is no. The diagnosis and treatment of hypertension rely heavily on an accurate blood pressure measurement. When we are adopting the concept of the lower the better for treatment of hypertension, we need even more accurate blood pressure measurement to help fine-tune the titration of antihypertensive medication. And inaccurate blood pressure measurement may cause overtreatment and undertreatment. Patients may suffer from adverse effects from antihypertensive medications and also suffer from cardiovascular events due to insufficient lowering of blood pressure. Since the cuffless blood pressure devices are not accurate, I think they cannot reliably replace the cuff blood pressure devices for diagnosis and treatment of hypertension. The third question, can the cuffless blood pressure devices supplement the cuff blood pressure devices for diagnosis and treatment of hypertension? My answer is maybe yes. One of the unmet needs for hypertension control is the low awareness of hypertension. Epidemiological studies consistently found that young adults usually have low awareness of hypertension. Since the accessibility to the validated cuff blood pressure monitors is still limited for the general population. Smartphone or smartwatch-based blood pressure measurement is conveniently available and could encourage young adults to pay attention to high blood pressure and start hypertension treatment early. However, this potential benefit of increasing hypertension awareness must be cautiously weighed against the potential harm to the true hypertensive individuals who may consistently receive low blood pressure readings from the inaccurate cuffless devices and may thus have a false belief of normal tension. And here's are my comments. Thank you very much.
Alberto, do you have some more not debate but
No,
your
I think
opinion on that?
I think it's fantastic. You've actually summarized the whole thing. I think you know, the idea to get non-invasive measurements is not new, right? Psychophysiology were doing this. They couldn't measure blood pressure in the cuff because the stimulus was spoiling the experiment, so they needed something different. The reason we got oscillometric blood pressure, because in the 60s, the FBI was looking for a lie detector, a reliable lie detector, and they tried tonometry, and they couldn't get consistent measurements, and then it was abandoned, and that's why we got the oscillometric technique, because the tonometry didn't work as a cuffless, as a non-operator dependent. So now we're at a different point, but there's obviously a lot of interest. Now, the question that usually comes up, and as I said, these issues I mentioned before are extremely important in standards. How do you safely provide a protocol for standards so that you have reliable and reproducible changes in blood pressure so you can calibrate a device? Not easy, not easy. And the standards are struggling with this type of thing. So the other question that comes up is, why do we want these devices to replace this sphygmomanometer? Maybe we should look at something else. Maybe they will tell us give us some other information. The Holter monitors give us information, maybe with some, I don't know, 60, 70, 80% yield in noise, in reliable measurements. That's pretty good. Maybe we can look at blood pressure profiles in people that may or may, it's not about the accuracy, it's the way these profiles are tracked during the day. If one could find some profile that could then be a type of, could discriminate a phenotype in hypertension, in addition to these thresholds, because these thresholds don't really exist in real life. They're in the figment of people's imagination. The reality is it changes all the time. Of course they exist as an average value, of course they do, and they work. We know that they work, and we know that the cuff sphygmomanometer actually works when used properly. But the problem is, how come there is low adherence to awareness and treatment and so on, if one can improve that in some way? So this is the question mark, that there are some questions that I don't know how to answer. I just put them in the paper just to get to provoke some people to think about it. And as I said, I think some of these confounders, the other problem is that every time you read a paper with a study of validation, it all looks very nice, you know, but the variability is such that when you look at the individuals, the use of the device in a person, it's not the same as having an average of 50 people at the standards, or 80 people that the standards require. So there's a difference between the accuracy and precision. If we might improve the accuracy, but the precision will still be not very good.
Okay, because time limited, we want to have Hae-Young Lee. Do you have some comments on the both of talks?
Yes, thank you very much to two lecturers from excellent researchers. I actually make co-work with Professor Seo, and I have a chance to review the development research result of Galaxy smartwatch. They showed very excellent accurate data in clinical research, but the extreme value, low diastolic blood pressure and high blood pressure, their data began to deviate, reaching 5 to 10 millimeter mercury. Professor Seo, if they get more data in high blood pressure or low diastolic blood pressure, that kind of deviation can be minimized by machine learning?
Yeah, I believe so. As Professor Avolio told in his talk, to estimate the blood pressure on PPG signal, we should adopt a very several more parameters like STT and VTT and so on. And all these data are not enough until now for the reproducible measurements by PPG. So as more and more data are collected, then the more much better prediction with the PPG signal can be achieved. And the other point is that always dealing with the extreme value is very difficult as a sensor developers, because wide dynamic range sense with high accuracy and high resolution is almost impossible. If you would like to widen the dynamic range, then we should sacrifice the accuracy. If you would like to keep on going the accuracy, then the dynamic range should be reduced. That is a trade-off. So that's why also the Samsung Galaxy Watch recommend users to measure the blood pressure with their device only in the resting state, not during exercise, because during exercise, the dynamic range fluctuates so much. So as a result, it is inevitable to, it is almost impossible to avoid the measurement error. So it is a challenge. However, as you told, if we gather more and more data with a big data analysis, maybe in the near future, the wristwatch type PPG device can predict, not exactly measure, but can predict the real blood pressure in some day.
And when I heard Professor Avolio's talk, I became very agree with your talk in one-point calibration technique is many weak point to make error during calibration process. Although 2-point or 3-point calibration, of course, better than 1-point calibration, but one person's blood pressure cannot have different value easily. So someone suggest me if during calibration we intentionally make different blood pressure by Basaba maneuver or exercise by inducing 2-point calibration intentionally, they can make better calibration result than the usual 1-point calibration method current now. So how do you think how to make better result during calibration, minimize calibration error?
You asking me? So
yeah, PPG based.
Yeah. Look, I think it's difficult. I think it's easy to increase blood pressure, not so easy to reduce blood pressure. It's not the same. And so the sense, and as the reason I did that sensitivity calculation to indicate that the sensitivity of the measurement is different at different pressures. So this is a little bit of the problem it's less. It might be less sensitive at different pressures, depending on even which site, you know. But assuming it's in the wrist, assuming we have watches, so you know the assumption is that the transit time ones usually have ECG and a pulse. And so there are. That was one of the reasons to do the arm change, where you can get a very good reproducible stimulus for changing the posture. So we did some things with pulse wave velocity and so on. So the postural change is one way, because if you lift up at the same time, you always get the same change in blood pressure all the time. You know, of course, you have the hydrostatic plus the systemic. So that is at least one way to increase and decrease simply by moving the arm up and down. You know, that is at least something that you can reproduce. You know,
because we have just 2 minutes, just give you 1 minute each to speakers. What is the future? One that Sir is very optimistic for the youth, for the future of the Cuffless measurement, but Alberto is one of the saddest thing in the world. What do you think? What is the future of the Cuffless measurement?
I think the future is that it's going to produce a lot of interest in industry. There's going to be a lot of engineers and programmers and artificial intelligence people employed in Google and Apple and so on, Samsung, to apply machine learning to noisy signals. The signals you measure with the PPG are noisy; they're not clean. Noisy. And then eventually come up with a prediction that is going to be within the acceptable standards, 5 plus or minus 8. There's going to be a lot of papers being published. Say, look, these devices work like a sphygmomanometer if you have enough measurements. And the problem is then, as Chen-Hua was saying, how to use it. Maybe, you know, I said, should it replace the sphygmomanometer? Maybe, I mean, supplement is probably better to use it together. And then, and I think the future of Cuffless, I think, is exciting because it might give us other information if we look at it a bit differently. Look at some other measure of blood pressure, not millimeters of mercury, something else.
Okay.
Not in millimeters of mercury, in something else.
Okay. Jongmo Seo, do you have some the optimistic future of the Cuffless measurement?
As I told my talk as a conclusion, the PPG-based blood pressure measurements will open another aspect of the BP measurement in daily life because of according to the data of the Korean Society of Hypertension with Galaxy Watch, the data is so much interesting. Those data already shows the reproducibility itself, and also the trend was very, very interesting. And also the analysis of those data can be done with a big data analysis in these days. So the traditional statistical, instead of using the conventional traditional statistical analysis, the big data analysis can provide much helpful clues and the results for the real clinical use. So I hope that the wrist-worn, the PPG-based device can reveal the white coat syndromes much more than the conventional devices.
Yeah.
Okay. Anyone else from the Kitcher-san or Chen? Just give me 1 minute. Give you 1 minute.
Maybe in the future, we will diagnose hypertension without actually measuring the blood pressure values. We may diagnose hypertension according to profile, some profile from the cuffless blood pressure monitors. It's possible.
Okay. 기철
Cuffless BP measuring is like a quick antigen test to detect coronavirus nowadays. It's not very accurate, but might be useful in some situation. Nowadays, we cannot do PCR test for every people in Korea. That's my opinion.
Okay. The time has come. Thank you very much for joining this the first webinar. Very interesting topics, and we want to have another session on the future. We are very optimistic on this device management, but you said too many said these things in this field, but the future will be replaced by hope. I hope so. And thank you very much. And this post webinar will be held bi-monthly. Next meeting will be held on early of the April. And the topic would be the impact on COVID-19 infection and its vaccine on arteries. We surely let you know. Thank you very much again for joining the first webinar. Very
Nice to see
appreciative
you, Professor Avolio and Professor Chen. See you again.
Yeah.
See you again.
See you.
Bye-bye.
Bye-bye. Thank you.